the whole the point of this talk would be how to manage a severe dengue in this particular modern era. This dengue has become a lot of monotonous kind of management. You see everywhere. If you see the diagnosis of dengue, the next question comes is what is a platelet or transfuse the platelets and all these things. But there has not been advances in the severe dengue management, and there are a lot of mismanagements also going on the entire world, especially in our part of world. So I thought this would be a great topic to discuss. So this particular discussion will be a little bit exhaustive discussion, because this is a very important topic where everybody of us should know, irrespective of our field. Even the MBBS students should know how to manage a severe dengue in the ICU. It's not the job of only physicians or the intensivists. So the present guidelines, whatever the guidelines just been provided by the WHO and the CDC, if you take, or if you take the NVBDCP, the National Vector-Borne Disease Control Program of India. So all these guidelines, if you see, they are based on the expert opinion. They are not the evidence-based. This is just a purely an expert-based guidelines. So, and these guidelines have been developed many years ago due to the understanding of the pathogenesis, which has been there in the earlier part. But a lot of things in understanding the pathogenesis has progressed in the recent years. And the earlier and even now, the hallmark of the dengue is the capillary leak. The one thing which we should fear in dengue is the capillary leak, the extravasation of the fluid from the intravascular compartment to the extravascular compartment. And apart from this capillary leak, a lot of the newer knowledge of pathophysiology have been coming to the picture. So hence there is a need for review. So this particular discussion, what I want to take is away from the guidelines. So you should not just follow the guidelines blindly. You should follow your own instinct and basic knowledge while following the dengue patients management. So if you see the overview, I will not be discussing the epidemiological aspects, the mosquito related aspects, and the prevention aspects today. This is pure a clinical kind of discussion. So let's stick on to that. So just for the sake of completion, we know that the infection of the dengue has been particularly increasing in the world. It is mainly due to the urbanization. So around 400 million cases we usually see each year. Among this, the 30% are usually symptomatic. And this greatest burden, that is 70% of this, is being seen in our part of the world, that is Asia, especially the Southeast Asia, the tropical and subtropical countries, which actually give the advantage to the transmission of this virus, including the survival of this particular mosquito called Aedes aegypti. So this particular part of world, that is which is close to the equator, that is tropical and subtropical areas, have got a very tremendous amount of disease burden of dengue. So dengue can have a various manifestation, can be completely asymptomatic, and we know that there is a classic dengue and some deviation from the classic dengue, which might present as a severe dengue. And recently there has been a terminology called an expanded dengue syndrome, that is EDS. So this has been the recent terminology nowadays. So a lot of variations and a lot of progressions are being going on in this particular field. So again, for the sake of completion, we know that dengue is mainly transmitted by two mosquitoes. One is, we know that is the Aedes aegypti. It is a major mosquito which transmits the dengue virus, and there is another similar mosquito called Aedes albopicus. So to some extent, the 90% of the disease burden is carried by this Aegypti mosquito, which is a similar mosquito which also transmits the other infections, like very importantly, the recent, that is Zika virus and similar chikungunya virus. This becomes a very, very important. And also sometimes yellow fever, although we don't see yellow fever in India, but in other countries, these particularly important, similar kind of illnesses transmitted by different viruses. So Zika, chikungunya, yellow fever, and dengue virus has been transmitted by the similar mosquito. So mosquitoes acquire infection from a person who actually carries the disease. So this comes into the mosquito where it survives, and it has got an extensive incubation period of 8 to 10 days where it infects the mosquito and eventually travels to its salivary gland. And from the salivary gland, when it bites to a normal person, so human usually acquires the infection. So this is what transmission goes on, which everybody of you might have studied in the PSM, etc. So why this is a global threat? Why the issue has been increasing nowadays? If you see, there is a rapid population growth in the worldwide. It's a very population. This I need not stress upon. And there is a very important rural to urban migration. Because of this, there is an inadequate basic urban infrastructure where the water management is poor, the drainage is poor, which ultimately leads to increase in the volume of the solid waste, which actually provides a good habitats for the larva survival in the urban areas. So urban areas, especially the metropolitan cities, carries a tremendous amount of risk. So if you see in dengue, there is a havoc in especially the post rainy season in the month of July to September. It is a havoc of dengue. All the government hospitals are filled with the dengue. All the departments have been converted into the dengue wards. The ophthalmology, ENT, orthopedic, all these wards have been shut down. I have seen every alternate year there is a heavy outbreak in the Delhi, which I was there. So even now, there's a significant risk and the damage burden is carried by the metropolitan cities. So again, dengue is mainly transmitted by the virus called dengue virus, that is Dengue. So there are 4 serotypes. So these are similarly looking kind of organisms, but although they vary genetically, so they genetically distinct, but they look closely related. So among this, the dengue 2 is the most studied, and it is responsible for the severe dengue. Although I have used the terminology called the DHF and DSS, the DHF terminology is not used nowadays. But if you, for the sake of remembrance, you should remember that the severe dengue is most commonly caused by the dengue 2, that is a secondary infection by dengue 2 is the most important risk factor for having a severe dengue. So this can be the entrance question. Although first infection of serotype 2 may not cause a severe disease, it is usually the second infection of the dengue which is significantly associated with the development of severe dengue. That too, a heterotypic presentation, like if there is a particular serotype infection in the first episode of a dengue fever, in the next second episode of dengue fever, if there is another serotypic involvement, like if the patient had an infection with a dengue 1 some months back, minimum around 1 year or 18 months, and after some years he has got an infection with a second serotype of dengue. So this person is particularly exposed for having a severe dengue. So this is a secondary infection with a different serotype. Is a major and the most important risk factor to have a severe dengue. So what has been changed in the recent understanding of the pathogenesis? So what does the recent updates say is it is not only the capillary leak which is being responsible, but it is a very important other immunological abnormalities which are seen in the dengue. The most important is the origin and original antigenic sin. So we'll be discussing this particular thing. And similarly, this original antigenic sin is associated with this particular immune phenomena called antibody-dependent enhancement, and there is an antibody-dependent cytotoxicity. So these three are the very, very important things in having a severe dengue. And these will definitely produce a cytokine storm, that is in cytokainemia, and an aberrant activation of the complement system. So there is a lot of immune abnormalities which usually seen in the dengue, which are responsible for this occurrence of severe dengue. So what is particular type called original antigenic sin? So I will give you an example here. For example, there is a person who has got an infection with a dengue virus serotype 1. So after the acquirance of infection, the body produces a corresponding T cells and the corresponding D cells to fight it over. So this will wear off the infection. So the first infection is usually a mild infection where the patient just have a constitutional symptoms, may not progress to the critical phase. But this will definitely produce memory cells. So what happens if a patient gets second infection? If the second infection is the similar serotype, for example, if this is also dengue serotype 1, that is called an homotypic reinfection. So the memory cells are already there. So these are ready to fight. So they produce tremendous amount of the immunity. So this antibodies and the cytotoxic T cells directly act on the corresponding serotypic virus to fight out the disease. So the second infection with the same serotype may not produce any significant disease. But if the patient develops a heterotypic infection, if the patient had a dengue 1 in the previous time, now he has got a different serotypic infection that is called an heterotypic infection. So for example, I have mentioned it is dengue 2 because it is the most common secondary infection which is responsible for this. So now the memory T cells from the previous infection, whatever the antibodies or B cells or T cells, memory T cells which are produced in the previous infection, now they become active. But after becoming active, they cannot completely cure the infection because there is a genotypic variation. There is some amount of antigenic variability from the one type of virus to the another type of virus. So they will not be able to completely cure off this infection. So this triggers the body to release the more and more B cells, more and more T cells, thinking that the infection is not going right away. So the body tries to produce more and more B cells, more and more cytotoxic T cells, so which will definitely result in the ineffective control of the dengue infection because these viruses are not meant to deal with this particular serotype. So this will cause an antibody dependent enhancement. So the antibodies, whatever the things which are produced, are not able to clear up the infection. So there is a flare up. So this will become an antibody dependent enhancement. So the more the antibody production, more the complement activation, more the cytokine storm, so which will progress to cause a particular disease called severe dengue. So I think I have made the concept clear of original antigenic sin, which is responsible for this particular occurrence of severe dengue. So earlier things, the severe dengue was considered as the abnormality in the only vasculopathy and some amount of coagulopathy. So there is endothelial dysfunction, which was the major abnormality which was considered in the severe dengue earlier, along with some coagulopathy. It may be secondary to the liver involvement or secondary to the platelet involvement. But nowadays, apart from the vasculopathy and coagulopathy, it is the cytokine storm and the secondary bacterial infection, a very, very important two things which are responsible for occurrence of the severe dengue and the deaths related dengue. Deaths in dengue is usually caused by either of these four. So it is either a severe vasculopathy or a severe coagulopathy or a cytokine storm, maybe presenting as HLH, which I have discussed in my previous case presentations, and also the secondary infection, which is the major important thing in dengue, which is least addressed in our part of world. So how does a severe dengue usually presents? As I told you, there is a coagulopathy, there is a vasculopathy, and there is a cytokine storm, and there is a secondary infection. So all these together produce a particular thing called plasma leakage. There is a fluid accumulation, and there is a respiratory distress. Along with this, there is severe bleeding and severe organ damage. Am I audible?
Yes, sir, you're audible.
Yeah, thank you. So the first three things, the plasma leakage. So whatever the intravascular fluid is there, which gets leaked through the endothelial gap junctions or the transcellular shift from the intravascular compartment to the extravascular compartment. So this causes an intravascular hypovolemia. Although total body fluid is okay, but the patient has an intravascular hypovolemia because a lot of fluid is being coming from the intravascular compartment to the extravascular compartment. So the extravascular compartment gets accumulated with the fluid. So this becomes very important if this occurs in the lungs. Patient might get pulmonary edema. Patient will get pleural effusions. Patient will get ascites. Patient may get facial puffiness. So everywhere the fluid leaks from the intravascular compartment to the extravascular compartment. So ultimately causing the respiratory distress, which can cause death, and severe bleeding due to the coagulopathy, and severe organ damage secondary to the intravascular hypovolemia. So if this intravascular hypovolemia persists, the organs which are perfused may get ischemic, which becomes a very important in causing severe organ damage. So if you see the statistics, approximately 1 in 10 people who become ill with dengue will go on to develop a severe dengue. Then people who have previously had a dengue are more likely to develop a severe form of the disease. This is particularly true when there is a heterotypic infection. And very important is in infants, the pregnant women, and older adults. They are also at greater risk of having a severe dengue. This is very important. So how the course of the dengue usually goes through. So this is a very important slide. Any dengue discussion which you take, this slide will definitely be there. So there are basically 3 phases. There is a febrile phase, there is a critical phase, and there is a recovery phase. Let's leave the recovery phase because it is a good thing. Come to the febrile phase. So once the mosquito bite occurs, the patient may completely remain asymptomatic, or he can become symptomatic with the dengue. The first phase, which usually goes through the febrile phase, so which usually stays for 2 to 7 days. So what happens in this particular thing is, the first patient will get a fever. So if you see the temperature, it is usually very high. So patient may get sudden high degree fever. It may be associated with the chills or may not be associated with the chills. Along with this fever, the patient may have a severe constitutional symptoms. So these are typically headache, myalgia, arthralgia. Patient may have a retroorbital pain. Patient may have conjunctivitis. Patient may have some URTI symptoms. Or patient may have sometimes the GI symptoms. Many of times I have seen the doctors ruling out dengue based on upper respiratory tract infection because just the patient presented with the URTI manifestation. So in the febrile phase of the dengue, patient can have URI manifestations like rhinorrhea, the coryza, the pharyngitis, mild amount of cough can be there in the dengue. So the presence of an upper respiratory tract symptoms does not rule out dengue. Is a very important thing which we should consider here. So in this particular phase, the patient can also have, along with the fever and constitutional symptoms, patient can have one very important symptom, that is a rash. So rash is usually a maculopapular one. And the rash is very common in the primary infection compared to the secondary infection. So the first infection of dengue is more likely to have a rash compared to the secondary infection. So this is very important to remember, because many of the times, just because rash is there, rash is not there, the dengue has been ruled out. So that should not be there. And this rash usually appears after the 2 to 5 days of onset of fever. So it is not a first day rash with the fever. You all know that the first day rash is usually associated with chickenpox. So the rash usually appears between the 2nd or 5th day of the fever. So this is very important. And this rash can be extensive. They can involve the trunk, it can involve the face, it can involve the upper limb, lower limb, many things. It may or may not be associated with the pleuritis. So this is a very important things about the rash. There is another type of rash which usually comes in the recovery phase of dengue. That is also called the convalescent rash. But it is usually not papular one. It is purely macular or just a reddish hue. And it is not associated with pleuritis, and it is usually appears only on trunk. So this convalescent rash, which appears in the recovery phase, you do not worry about anything. So this is very important. So what will you see in the febrile phase once you examine the patient? The patient may have dehydration. The patient may have dehydration. Along with this, patient can have the hepatomegaly, sometimes splenomegaly, although hepatomegaly is more common than splenomegaly in dengue. And the patient may have mild abdominal tenderness. Patient may have again evidence of ascites or pleural effusions once it is during the bridging between the critical phase and the febrile phase. And one very important thing which you should usually look for in the febrile phase of the dengue is the tourniquet test. Why I am telling all this matters. So the tourniquet test is a very important thing which you should remember. Is we'll be discussing tourniquet test in the due course. So next, sometimes after crossing the febrile phase, some patients will directly go to the recover phase, while some patients enter the critical phase. So this critical phase is a phase of plasma leakage, where which everybody of us should be very careful in managing the dengue. So when this critical phase occurs, it usually occurs after the fever subsides. So if you see this, the fever has subsided. Now the critical phase usually is a risk. So it usually occurs during the phase of defervescence for the next 12 to 48 hours. A very important period in dengue is after the fever has been defervescent. So once the fever reduces in dengue, you have admitted the patient, the fever is low now, you should be very careful for the next 48 hours. You should not discharge the patient just because the patient has recovered with the fever. So this is a phase of plasma leakage. So if this plasma leakage is not been addressed, if the patient is not been monitored particularly, the patient will be having to develop a severe dengue, which is a major worry. If this critical phase also gets over, whatever the plasma leakage has been occurred will slowly get reabsorbed back into the intravascular compartment during the recovery phase. So this is basically how the clinical course of dengue occurs. So usually dengue has three phases. The febrile phase and recovery phase is there in all the patients, whereas critical phase is seen only in some patients, where we need to be very careful. And where does the severe dengue or the critical phase occurs is after the subsidence of fever. So it is usually the between the day 3 to day 7, and 1 to 2 days after the patient's fever is starting to subside. A very important thing to remember, and it can become life-threatening very quickly. So for example, if you're taking rounds in the morning, if your next rounds in the next day, it is not going to manage the dengue properly. In dengue, you usually take every 2 hourly rounds or every 3 hourly rounds to monitor the patients. So it is very important to manage the patient or monitor the patient every hourly in this critical phase. So how the dengue is being classified now? Earlier, dengue was classified as dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. Nowadays, this particular classification is not being used. It has been abandoned by both the WHO and the CDC. Nowadays, dengue is being classified as three varieties. That is the dengue fever, next dengue with warning signs, next a severe dengue. This is a classification and it is a diagnosis which you should usually write in the case sheet also. When you write the case sheet, you are dealing with either a patient of dengue fever or a dengue fever with warning signs or a severe dengue. So how to see which category your patient lies? So the dengue fever is a probable dengue when the patient lives or he has a history of travel to the area which is endemic for dengue. So if we Indians are living in an area which is endemic to dengue. So along with this epidemiological risk factor, the patient need to have three important features. Fever has to be there for 3 days. It's a very important thing. Along with the fever, 2 of the following criteria should be there. Either nausea, vomiting, or rash, or the aches and pains, the tourniquet test being positive, the leukopenia, and any warning sign. If any warning sign is there, then it becomes a probable dengue. So this probable dengue can have a warning signs, or they can be there without warning signs. So what are these warning signs which you should usually look for? One is a very important thing is the abdominal pain or the tenderness, the persistent vomiting, the clinical fluid accumulation, the ascites or pleural effusions, the pedal edema, or the facial puffiness. Can be anything. And some amount of mucosal bleed, the lethargy and restlessness being the manifestation of CNS involvement. The liver enlargement is typically if it is tender and if it is more than 2 centimeters. And there is a laboratory manifestation of increase in hematocrit. It is more than 20% from the baseline, or if there is a rapid decrease in the platelet. If you admitted the patient, the platelets are very good. I have seen in emergency, they usually send 2 to 3 times platelets in a patient of dengue. So it has been coming 1.3 lakh, 1.4 lakh, 1.6. But suddenly you take a reading, it comes 60,000 or 50,000. So this becomes a rapid decrease in platelet. Many of the times it has been attributed to the laboratory error, but a sudden decrease from 2 lakhs to 50,000 can occur within hours in a patient of dengue. And it is a feature of a warning sign where the patient needs to be very carefully managed. So these important symptoms you should be remember in a patient of dengue. So whenever the patient of dengue is admitted, you keep the hand on abdomen, look for tenderness and look for the liver enlargement. Examine the mucosa for the bleeds, ask for persistent vomiting, look for fluid accumulation in the ascites, pleural space, and the pedal edema and the facial puffiness, and see for the lethargy, restlessness of the patient, and look for the laboratory. The 2 laboratory things which usually you should look for is the hematocrit, the platelet, and along with its WBC. The leukopenia carries this increased risk of progressing the patient into the dengue, severe dengue. So the 3 important things which you usually look for in the patient of dengue in hemogram is TLC. First thing to go low is TLC. Next is you look for platelet. Next for the hematocrit. Next for HB, hemoglobin. That is a drop in hemoglobin is a significant risk factor for a hidden hemorrhage which is going on in this patient. So please look for this warning signs. If the patient has got warning signs, then the patient needs to be admitted. The patient needs to be given a proper treatment, which I will be discussing later. Then what is severe dengue? The severe dengue is being labeled for 3 things. One, there is a severe plasma leakage, or there is a severe hemorrhage, or a severe organ impairment. What do you mean by severe plasma leakage? How do you know that there is a severe plasma leakage? One, if the patient has got a shock just by the occurrence of the ascites, pleural effusion, the pedal edema, the facial puffiness may not make it a severe dengue. If this fluid accumulation is associated with a shock, or if this fluid accumulation is associated with the respiratory distress, patient has gone into ERDS or patient has gone into respiratory failure. So this will become a severe plasma leakage and makes the patient a diagnosis as severe dengue. Then if there is severe bleeding as evaluated by the clinician, if the patient have intracerebral hemorrhage, if the patient has a hidden GI hemorrhage, if the patient is having a pericardial hemorrhage, if the patient is having a PR bleeding, so upper GI bleed, hematemesis, all these will become severe dengue. And the severe organ impairment. So this organ impairment in the liver usually manifests as an ischemic hepatitis with the AST to ALT ratio of AST or ALT going very high. It is more than 1,000. Is usually a feature of an ischemic hepatitis. And a CNS, an impaired consciousness. If the patient has got the impaired consciousness, sometimes they present with the status. And the heart and other organs may also develop the organ dysfunction. The patient can have an AKI, the patient can have myocarditis, the patient can have frank heart failure. So these can become important in severe organ impairment, which makes the patient diagnosis corresponding to the severe dengue. Very, very important. So to summarize, the dengue is classified as dengue fever with warning signs, and severe dengue warning signs. You should remember three things in severe dengue. If there is severe plasma leakage, that means either the patient is in shock, or if there is a respiratory distress, the severe bleeding as evaluated by the clinician, and the severe organ impairment. So again, this is the same slide with a different infrastructure. So what are the warning signs which you should look for in the history? Ask for the bleeding and the vomiting, and look for rapid breathing. Look for the severe abdominal pain, ascites, pleural effusions, and look for lethargy and restlessness. Along with this, look at the hematocrit if it is increasing, especially if it has increased from more than 20%, and a drop in platelet, especially if it occurs suddenly, then it becomes a very important warning sign. So what is this tourniquet test, which we usually look in the dengue? Is a very important thing. So it is also called Rumpel lead tourniquet test. So what we do here is, while checking BP, for example, if the patient has a BP of 120/80, so inflate the cuff midway between the systolic and diastolic, so at 100. So inflate the cuff to 100 mmHg, which is between 120 and 80. So keep it for 5 minutes. Then deflate. So during this inflation, or within 2 minutes after deflation, take an area of 1 square meter, 1 square centimeter. So look for the number of petechial hemorrhages. If this is more than 10, then it becomes a positive tourniquet test, and it is one of the warning signs for dengue. So what does this suggest? So this does not suggest thrombocytopenia. Please remember this. Tourniquet test does not suggest the presence of thrombocytopenia. It suggests the presence of capillary leak. This is a very important thing which everybody of us should remember. And this is a very important question being asked during the exam for both undergraduates and postgraduates. The tourniquet test is not done to evaluate the presence of a thrombocytopenia. It is a test to evaluate the presence of capillary leak. So dengue, we know that it can affect all organs in the body, and it can cause complications in all organs except arthritis. So one thing which dengue does not cause is arthritis. It can cause arthralgia, but it does not cause a frank arthritis like chikungunya. So there will not be any swelling, there will not be any tenderness, there will not be any restricted movements, there will not be any morning stiffnesses, which are usually seen in the dengue. Sorry, chikungunya. Dengue can have arthralgia, but it cannot have arthritis. Whereas apart from this joint involvement, it can cause all complications. So in the epidemic type, rule out dengue in all patients with fever. If there is an epidemic going on, or if you are in a hyperendemic area, you need to rule out dengue before going on to the further diagnosis. So the clinical feature, again, I did not stress away. I have told you what is going to occur in the febrile phase of the dengue. If you take the organ-wise involvement, the CNS involvement, it can have an encephalitis. It can have aseptic meningitis. Sometimes it can present with the seizures or status epilepticus or encephalopathy. But usually the dengue encephalopathy usually recovers spontaneously. It does not carry a bad prognosis. But especially if the patient is status and the patient has got the significant other risk factors like uncontrolled diabetes, all these are make the patient have poor prognosis. Then coming to the cardiac, the patient can have a myocarditis. It can be a very, very important and very complicated thing to occur in the dengue. In the lungs, the patient can have pleural effusions as a part of capillary leak. The patient can have an ARDS due to the extravasation of the fluid. In the muscle, it can cause myalgia. Sometimes a myositis can occur. in the dengue. In the bones, it is usually arthralgia, but it does not cause arthritis. In the kidney, it can have an acute kidney injury. GI, it can cause the liver involvement, especially in the form of ischemic hepatitis. Or dengue can also cause an infective hepatitis by its own, like the virus hepatitis A, the adenovirus. Like this, the dengue by itself can cause some amount of hepatitis, and the patient can have the GI involvement in the form of enteritis and the ascites. So the various type of organ involvements are usually seen in dengue. So abdominal pain in dengue can be troublesome. You should know what all can cause the abdominal pain in dengue, so that it's very important to manage abdominal pain. So abdominal pain can be usually due to hepatitis, but it can also be due to the presence of an ascites. Remember, it is an acute ascites developing in a patient. If the ascites is chronic, like in the case of the chronic liver disease, if the patient of tuberculosis, the ascites usually does not cause any pain in the abdomen significantly. Whereas in dengue, since it is an acute ascites, patient can have pain itself due to ascites. Sometimes the patient can have pancreatitis in a dengue, very rare although, and gut edema. As I have told you that there is a vascular leak. If there is an intestine, if you think this is an intestinal wall, there is a mucosa, there is a submucosa, there is musculus propriae. So there can be a gut edema, which can be responsible for unexplained pain. And very importantly, and which we should be very cautious of, is an intra-abdominal bleed. It can be hidden. The patient may not have any external bleeding. It can be completely internal. So the only manifestations would be the severe uncontrollable abdominal pain, the dropping hematocrit, and the hemodynamic instability. So remember that the dropping hematocrit in dengue is usually suggestive of hemorrhage. There's an increasing hematocrit in dengue is usually suggestive of a capillary leak. What other abnormalities are usually seen in the dengue is the paradoxical infarcts. So dengue is a usually a state of hemorrhage because of the inherent coagulopathy, or it can be due to thrombocytopenia, or it can be due to liver involvement due to abnormal in the coagulation. So usually dengue have a bleeding manifestations. Sometimes dengue can have infarcts. That's why it is called as paradoxical infarcts, which is a paradox in dengue. So the paradoxical infarcts in dengue can occur. It can manifest as the ischemic stroke. It can also manifest as splenic infarcts. It can also manifest as the mesenteric ischemia. So it can have a variety of manifestations, but it usually second is the reason for this infarct is the secondary vasculitis, which occurs in dengue. So dengue is one of the cause for secondary vasculitis can be seen. Another infection which can have a secondary vasculitis is a malaria and also the tuberculosis. The tubercular vasculitis can cause a stroke-like picture. So this is very, very important to remember that dengue patient can also have an ischemic manifestation like infarcts or thrombosis occurring in the body. So just because the patient has infarct or if the patient has DVT, you cannot just rule out the dengue. So what if the fever persisting beyond 1 week in a proven dengue? You have proved that your patient is dengue, but fever is not subsiding. Then you need to suspect the patient might have developed a secondary bacterial infection, or if there is a co-infection, especially the enteric fever, very important thing, and a very significant thing, a co-infection with the dengue plus enteric fever or typhoid fever, or a co-infection with the dengue and malaria are very, very important and very, very common also. And a secondary HLH, one of the complication of severe dengue, which is a nowadays it has been involved in the expanded dengue syndrome. So the fever can be, the persistence fever can be secondary to the development of secondary hemophagocytic lymphohistiocytosis and usual ICU causes. It can be due to ventilator-associated pneumonia, or it can be due to hospital-acquired pneumonia, it can be due to catheter-associated UTI. So all these usual cases should be considered when the patient is in particular that amount of risk factor. But otherwise, what is important is you need to rule out the co-infection, either enteric fever or malaria or chikungunya, or the secondary HLH, especially if the patient has other manifestations also. If there is a dropping blood counts, there is pancytopenia, if there is rising liver enzymes, if there is a severe increase in ferritin, the patient has developed spleen. So all these will become a risk factor towards the secondary HLH. And very important is the secondary bacterial infection. You might, if you go through the literature, you get a lot of studies based on the secondary bacterial infection and mortality in dengue. So what all can cause hypotension in dengue? If you see the dengue patient and if the BP is 90/60 with a mean arterial pressure of 60 or less than 60, so there is a hypotension or shock. So what all can be the reason for dengue patient to have a hypotension? So very importantly and obviously, you need to look for this particular thing, that is dengue shock syndrome, which is an uncontrollable vascular leak. Apart from this, there are other things also which you look for. If you think if it is a dengue shock syndrome, the management is different. Just because if the patient is in shock and he's a dengue, it does not mean he has a dengue shock syndrome. There are other reasons also, like patient can have a hemorrhagic shock. The patient can have a gram-negative sepsis with a septic shock. Remember, septic shock is completely different from the dengue shock syndrome. And the management is also different. The patient can have a severe LV dysfunction, especially secondary to the myocarditis, which has been usually one of the clue which I usually consider is the unexplained tachycardia which is going on in the patient, especially if there is a disproportionate tachycardia with the age. And along with this, there is a rise in cardiac enzymes, particularly the CK-MB, so which usually goes towards the myocarditis, and an adrenal hemorrhage leading to this Waterhouse-Friderichsen syndrome or the hypoadrenalism or acute Addison's. So it can be an Addison's crisis you are dealing with, it can be a myocarditis you are dealing with, which might demand the need for the inotropic support. So there is a gram-negative septic shock which can cause the shock. The fluid department is completely different. In case of the shock syndrome, it can be hemorrhagic shock, which demands the transfusion of blood, and there is a dengue shock syndrome, definitely needs the fluid management, which is completely different from the shock of the sepsis. So what is dengue shock syndrome? Why does it occur? So it is usually due to a massive capillary leak. As I told you, there is a capillary leak which is occurring in the dengue. That is, a lot of fluid in the intravascular compartment is going to be pushed into the extravascular compartment. So there is a hypovolume in the intravascular compartment which can cause a shock. So when does it occur? It usually occurs 3 to 7 days, between 3 to 7 days. It usually does not occur less than 3 days and usually does not occur after 7 days. 3 to 7 days is the ideal time for the occurrence of this dengue shock syndrome or the severe dengue. If you see a hypotension with a less than 3 days, you usually suspect the algid malaria or a cerebral malaria or a complicated malaria, or if the patient has leptospirosis, all these acute kind of infection. If it is more than 7 days, then it is usually HLH, enteric fever, all these things. So between 3 to 7 days, a dengue especially corresponds with the defervescence. The subsidence of fever and the going into hypotension usually coexists. So this is heralded by the worsening of the condition. So you see that in the rounds, the patient does not have any fever, but the patient is worsening. The patient does not look good. Patient looks sick. Shooting his heart rate into 120, 130, having severe pain, severe vomiting, the hematocrit is rising. And the objective evidence is by the narrowing of pulse pressure. So we know that septic shock, there is a widening of pulse pressure because of the drop in the diastolic blood pressure due to the vasodilatation. Whereas a dengue shock syndrome is a state of vasoconstriction. So there is an increased peripheral vascular resistance, which can cause a slight increase in the diastolic BP and a drop in systolic BP due to the capillary bleed. So ultimately narrowing the pulse pressure. So the question exists, what happens to the systemic vascular resistance in dengue shock syndrome? Ideally, it should increase due to the vasoconstriction, but it is not true. A lot of studies are going on nowadays. If you see the critical medicine, this has been a very important question to answer nowadays. What happens to systemic vascular resistance? But as of now, Let's remember that there is dengue is a state of vasoconstriction due to sympathetic overactivity, so which usually increases the diastolic blood pressure, and there is a drop in systolic blood pressure due to the vascular leak, ultimately narrowing the pulse pressure. So it typically reverts in 48 hours if treated well, or the patient is going to be having a severe dengue or going to die in the 48 hours. So it's going to respond very rapidly and going to increase in severity very rapidly also. So what is very important in managing dengue is you need to monitor the patient very closely, focus on the patient for the early detection of the shock, especially the plasma leakage, if there's significant bleeding and an expanded dengue syndrome. Avoid fluid overload, very, very important thing. And use a hypertonic colloid or plasma volume expander if there is a response to crystalloid infusion is very inadequate. These are very, very important things which we'll be discussing. So the key message here is, even though we don't have any specific antiviral treatment in the dengue, but early recognition, timely administration of the supportive care is very, very important. We definitely improve the clinical outcomes substantially and reduce the mortality and the case fatality rate. So the key principle is identifying and the timely management. Because time is very short, you just have the 24 to 48 hours to prevent death. So how to diagnose the dengue? So dengue diagnostic testing is a very, very important. Let me go through this very briefly. So there are direct methods and there are indirect methods. In direct method, you are either directly isolating the virus or you are detecting the genome by the RT-PCR. Here you can detect the viral RNA, or you are detecting some antigen produced by the dengue virus. It is usually the NS1, that is non-specific 1 type of antigen which can be detected. There are indirect methods. So you can either detect the antibodies, which is IgM or IgG. So the direct methods, they usually confirm the infection. They are easy to perform, except the viral isolation, which is very difficult and very costly also. And they also detect the primary and secondary infection. Even the serotype can be identified. And it is less expensive than the virus isolation and RNA detection, especially this antigen detection. But it is less sensitive than the viral isolation and the PCR. And if you see the indirect methods, they also confirm the infection. They're easy to perform, they're least expensive, but the confirmation usually requires 2 or more samples. The IgM is an acute antibody, the IgG is a chronic antibody. So if you see the timing of this, very, very important is, look at this, the time of criticality. The time of criticality usually corresponds with the NS1 negativity and the IgM positivity. So if you see the patient, if your patient is NS1 negative, IgM positive, you need to be very, very, very careful in this particular time as the patient is in his critical period. So this is how you judge how to monitor the patient. So IgM positivity with the NS1 negativity or reduced NS1 quantity, so usually depicts the presence of a timing where the patient can go into the criticality. So IgG is a later coming antibody. So if you see this difference between the primary infection and secondary infection, in the primary infection, the major antibody which comes into the picture is the IgM. And although IgM occurs much later, but if there is a secondary infection, especially from the similar virus, that is a homotypic reinfection, IgG is a significantly high titer compared to the IgM. So I have seen that if for example, if there is an IgG positivity, IgM negativity, and NS1 negativity. So this can occur in the previous dengue, if the patient has previous history of dengue, or if the patient is an acute infection of dengue after 7 days, especially if there is a rise in quantity which you can detect. If the quantification it can be done for the IgG, this becomes very, very significant to diagnose the dengue. So the COVID-19 and the dengue, any infection, we need to consider what is its relation to COVID-19. So we went through the dual epidemic last year. the COVID-19 pandemic threatens to overwhelm the healthcare systems, so especially the countries which are epidemic for the dengue. And initial presentation can be very similar to the dengue or COVID, which is there is a lot of similarities between this. So there is a risk of delay in the diagnosis and the misdiagnosis. So COVID is a disease of thrombosis, and dengue is usually a disease of hemorrhage. So the right diagnosis is very, very important here. So there is a lot of similarities, coexisting factors, but it is predominantly respiratory and it is predominantly constitutional. Although there is common features like the fever, myalgia, headaches, the associated leukopenia and thrombocytopenia with abnormal liver test can be the co-sharing. Although the dengue can have the upper respiratory manifestations and COVID-19 can have a constitutional symptom. So what is common between dengue and the COVID, if you see? The only difference is it is transmitted by the mosquito. It is transmitted by the aerosol or droplets from the person to person. So, but they have a similar incubation period. If you see, the incubation period is 4 to 8 days. And both are the diseases of capillary leakage. Both have coagulopathy, although mechanism is different. Both can have a skin manifestations. In both the infection, the CRP is increased, D-dimer is increased, interleukin 6 is increased. In both the pathology, there is an immuno phenomena called an antibody-dependent enhancement, and both possess a single-stranded RNA as genetic material. So there might be a possible antigenic cross-reactivity. Why this is important? Because, for example, if the patient has a COVID infection in the previous, so there is a protective antibodies which are produced in the body. If the patient has dengue infection, since there is a similar amount of antigenic cross-reactivity, even the first infection of this dengue can become very severe. That is why this particular slide I have put down. So previous history of COVID might increase the risk of having a severe dengue in this episode. So since the Zika, dengue, and chikungunya are transmitted through the same vectors, so let me go through the similarities. Fever is significant, especially in dengue and chikungunya, but Zika, it is there, but not much significant. Rash is a very significant symptom in the Zika. And specific factors, if you look for this, is an arthritis. If the patient has an arthritis, especially if there is a prolonged morning stiffness like RA, usually goes in favor of chikungunya. The arthritis are usually not seen in both dengue or Zika. And the bleeding manifestations, if you see the hemorrhage, it is a specific feature of the dengue. It is usually not seen in the Zika. It is not a hemorrhagic fever. And also chikungunya is usually not a hemorrhagic fever. And also Zika, the shock is usually not seen. A chikungunya patient also does not go through the shock. So these are a significant amount of differences. Otherwise, a lot of co-sharing is there. So how to take the management decisions in dengue? First one is look for what phase of the dengue is in patient and look for whether warning signs are present or not. Look for the hemodynamic status and the urine output. Look for the laboratory test. The very, very important thing is hematocrit. The first thing you will see in a patient of dengue is a hematocrit. Next, you will see the platelet. Look for the baseline hematocrit or previous hematocrit. Compare this with the hematocrit of present. Next, you need to look for other things like the blood investigation. You need to look at ABG, the calcium, the sugars, etc. And hemorrhage, especially if it is concealed. So what are the don'ts in the dengue provided by CDC? This is very, very important thing. Here, don't use corticosteroids. They're not indicated and they increase the risk of GI bleeding and hyperglycemia and immunosuppression. I have seen many of the patients putting patient on Dexol, methylprednisolone, if their platelets are not improving. This is a very, very wrong practice. This is not an ITP you are dealing with. This is a dengue, which is a completely different disease. Don't put steroids if it is not indicated. And don't give platelet transfusion for a low platelet count. See this given by the CDC. CDC does not allow the prophylactic platelet transfusion, irrespective of the count. Even if it is 5,000, CDC does not allow the prophylactic platelet transfusion. Only if the patient is having a bleeding. This is a symptomatic platelet transfusion. Yes, you can do this irrespective of the platelet count. Even if the patient is 50,000, 60,000, if it is bleeding, yes, the platelets are justifiable. The platelets are not justifiable prophylactically, irrespective of the count. Although Indian guidelines say that less than 10,000 is an indication for a prophylactic platelet transfusion, but CDC tells that don't transfuse platelets. Why? Because they do not decrease the risk of severe bleeding, one thing, and they may instead lead to the fluid overload and they prolong the hospitalization. The fluid overload increases with the platelet transfusion. And don't give hypotonic saline, especially the half normal saline. If very, very important thing, the half normal saline should not be given even as a maintenance fluid because it leaks into the third space and may lead to the worsening of the ascites and the pleural effusions. Very, very important thing. So the mechanism is very simple. So you are giving a hypotonic fluid. So there is a reduction in the tonicity of the intravascular compartment. So the fluid moves from the hypotonic area to the hypertonic area. The fluid again starts moving out from the intravascular compartment. So don't give any hypotonic fluid during the dengue. And don't assume that IV fluids are necessary. A very, very important thing is first check if the patient can take fluids orally or not. Use only minimum amount of IV fluid to keep the patient well perfused. So this is not a case of septic shock where you are go on giving the fluids blindly. It is just given to keep the patient well perfused. And decrease the IV fluid rate as the hemodynamic status improves and rapidly. You are giving patient 10 ml per kg per hour fluid now. Within 1 hour, you can decrease the patient to 5 ml per kg. That is what's the case in dengue. So you need a very, very important, careful assessment of the hemodynamic system of the patient. You need to be very careful about the fluid management, and you need to have a tremendous amount of knowledge for this also. So this is an outpatient management. To be simple, you can go through this particular slide when I give the slides. Again, as I told you, the prophylactic platelet transfusion in dengue patients are not beneficial and may contribute to fluid overload CDC. This is irrespective of count. Whereas this NVBDCP tells that prophylactic platelet transfusions can be given if it is less than 10,000, less than or equal to 10,000. It depends on your particular hospital situation. So this is an issue which I think 2 weeks back, the juice transfused not platelets, the UP hospital sealed dengue patients. So there was a claim by the patients that the patient was transfused the Mosambik juice instead of the platelets, although they look similar. I don't know that this is a real news or it is a propaganda by the attenders. So you need to be very careful. Just don't transfuse platelets blindly irrespective of platelet count. So the fluids should not be too little, they should not be too much, and they should not be too late. This is what is the entire dengue management goes through. So you need to have a tremendous amount of the fluid balances and management system to manage the patient of dengue. So when I take the classes in critical care, I will be dealing the fluid balances and how to do the IV fluids. Only dengue, I will be discussing the fluids here. So give just enough fluids to maintain the good tissue perfusion and adequate urine output. So this 24 to 40 hours, you need to be just maintain the tissue perfusion. Don't allow the patient to go into severe organ impairment or the shock or the bleeding. So you need to be careful in the fluid management. So and differentiate dengue from COVID-19 and chikungunya. So you need to go through this particular slide also to identify the what state of the patient is in shock, whether the patient is in stable circulation system or is compensated shock or hypertensive shock. In the compensated shock, which I want to very, very importantly remember is patient BP can be normal, although he can have a narrow pulse pressure or he can have a postural drop, but there is a tachycardia for the age and there's pool periphery with the prolonged capillary refill. The hypotensive shock is the patient actually in hypotension, and there may be a severe tachycardia or there may be bradycardia. The bradycardia is seen in a late severe dengue. So if you are seeing a patient in bradycardia of dengue, then you already crossed all the stages in the management. How to differentiate between the dengue shock syndrome and the septic shock? You know that the systemic immune response is usually less in case of dengue, whereas it is very important in pathogenesis in the septic shock. The mental status is usually better, where it is worse in septic shock. The patients are usually normothermic in dengue shock syndrome. The patient might have fever or the hypothermia in septic shock because DSS occurs in the defervescence. So tachycardic response in dengue is usually suboptimal until there is a decompensation. In the decompensation only there is an extreme tachycardia. Whereas the septic shock tachycardia is seen very early and it usually reflects the degree of the circulatory problem. The bleeding is more in case of dengue, whereas irrespective of the thrombocytopenia, the bleeding usually does not occur in septic shock. These are the clinical differentiations between the dengue DSS and the septic shock. The mechanisms, if you see, what type of shock is dengue shock? It can be a very important question. This was a question asked to me in my medicine PG Viva. So the dengue shock is a hypovolemic shock, whereas the septic shock is a distributive shock. So there is a tremendous vasodilatation occurring in the septic shock, whereas there is a vasoconstriction occurring in the DSS. The mechanism in dengue is an increased vascular permeability, but without any morphological damage. If you see the endothelium, there may not be any damage, although there is a endothelial gap junction abnormality which has been seen in the electron microscopy. But in case of septic shock, there is a disruption of glycocalyx which can cause a sudden severe vasodilatation. So how the fluid loss occurs? The fluid loss occurs in dengue as a slow and intermittent periods of the microvascular dysfunction. It is not a continuous process and it is not a fast process. It is a very slowly occurring over 24 to 48 hours. And there are intermittent periods of microvascular dysfunction. And sometimes a very rapid fluid administration during this slow vascular leak can lead to pulmonary edema. So this is a very, very important thing. That's why the requirement of fluid during the resuscitation in dengue is much, much lesser compared to the septic shock. In the shock of dengue, we usually give 20 to 20 ml per kg, whereas in case of dengue, septic shock, we usually give 30 ml per kg. So, and the transfusion decision in dengue is usually aggressive, whereas in case of septic shock, the blood transfusion is classically practiced as a restrictive transfusion strategy, where blood is transfused only if the HB is less than 7. So this is how to manage a compensated shock is being given by CDC. So how to resuscitate the dengue fluids? So what are the fluids which are available for the management? Either crystalloids or the colloids. So usually we prefer the crystalloids. So the crystalloids, there are mainly two things which we should know. That one is normal saline and the ringer lactate. So normal saline contains 154 milliequivalents of sodium and 154 milliequivalents of chloride. So together, its osmolarity becomes 308 milliosmoles. So it is slightly higher osmolarity compared to the plasma. The plasma osmolarity is between 280 to 290. So there is a slightly hyperosmolar. So nothing is normal about the normal saline. Normal saline is actually an abnormal saline. And there is another crystalloid very commonly used is a ringer lactate, which contains lesser amount of sodium, but contains lactate and potassium. So very, very important in a patient when you transfuse in a patient of liver abnormality, because lactate is being managed only in the liver. So if you are giving more and more lactate in a patient of a liver abnormality, the patient can have a lactic acidosis. You need to be very, very careful. So the colloids, if you see, usually are used only when the patient is not being responding to the crystalloids. So there are only 3 colloids which can be used in the dengue. One is the 5% albumin, which is also called as an isotonic albumin or hypotonic albumin. Next, FFP, you can use a fresh frozen plasma. And you can use other synthetic colloids, but the only thing which we usually use is the dextran 40 in the dengue resuscitation. So these are the only 3 colloids which are being allowed in the dengue. You cannot use the H starch, you cannot use the gelatin, and you cannot use any other colloids during the management. So it is either a 5% albumin or an FFP or a D40. Very, very important. And the dose for all is same. It is usually given for 20 to 20 ml per kg per hour. Sorry, 20 to 20 ml per kg for 1 hour. I'll be discussing this in the due course. So how much fluid to give? It is very, very important. The fluid infusion is a critical phase. Is given. How the fluid infusion in critical phase is given? It is given with caution, and it is sparingly just to maintain an adequate amount of blood flow to the organs. This is very, very important. This is just to maintain the organ perfusion. So this usually does not exclude 5 to 6 hours during the 48 hours. So in less than 1 to 2 days, the maximum amount of fluid you can give is 5 to 6 liters. Usually it does not exceed more than that. So it is just to maintain an adequate urine output of 0.5 ml per kg per hour. And the hematocrit is to be checked every 1 to 2 hourly. And one important thing which I usually practice, I have included the point here, is to have a look on the serum albumin, which usually correlates, because a declining serum albumin in a patient of dengue correlates with the presence of plasma leakage. There is a still plasma leakage is going on in a patient of declining serum albumin. Whereas if the plasma albumin is increasing, that means there is an onset of reabsorption. So the patient has crossed the critical period. He is now into the recovery period. So this is very, very important to keep an eye on albumin. If you see the morning albumin, it is 3.3. If it is now 2.5, that means it's still going on into the plasma leakage. Now it is 2. Yes, plasma leakage is going on, especially in the background of rising hematocrit. And very, very important to assess the pure blood supply to the liver is the AST to ALT ratio, very, very important, or the single value of, especially if it is more than 1,000. Now it has become 2,000. That means the liver is not getting perfused, and also the rising lactate depicts the ischemia to all the organs. So all organ ischemia is usually done by the lactate count, and liver ischemia is usually assessed by the elevation of AST above 1,000 level. So this is a very, very important. Also, LDH can also be considered for the ischemic hepatitis. So you need to just perfuse for the maintenance of adequate fluid, maintain the good urine output. The fluid usually does not exceed 5 to 6 liters in 48 hours. Look for albumin for the extra knowledge, and look for the liver and other organ perfusion. So how to manage this patient with the dengue with plasma leakage? So if dengue plasma leakage means the dengue with warning signs. I have told you that what are the features of the warning signs. If there is a vomiting, if there is a severe tenderness in the abdomen, if there is a hepatomegaly, there is a rising hematocrit, if there is a rapid decline in platelet, if there is lethargy and confusion, and a positive tourniquet test. So all these are the features suggestive of the warning signs. This suggests the presence of the plasma leakage. So how will you go through this? Start the fluid at 5 to 7 ml per kg per hour. Give them fluid. After 1 hour, assess the hematocrit. 1 hour, please remember this, or 1 to 2 hours. If hematocrit is increasing, or if the patient's condition is not improving, still persisting abdominal pain, still vomiting, increase the fluid to the 7 to 10 ml per kg per hour. From 5 to 7, it is increased to 7 to 10. If the patient is still not improving, manage him as dengue shock syndrome. This is a very, very, very important thing. So in a patient of worsening hematocrit, start the fluid at 5 to 7 ml per kg per hour, increase it to 7 to 10 after 1 to 2 hours if there is no improvement. Even if you have reached 10 ml per kg per hour, if there is no improvement, you need to manage him as dengue shock syndrome. Whereas you have started the fluid at the 5 to 7 ml per kg per hour, if the hematocrit is, yes, it is dropping. Plus patient's symptoms are improving. So this is not only the improving hematocrit, also the improving symptoms. If the hematocrit is dropping, but symptoms are not improving, that means the patient is having bleeding. So the symptoms should also improve, the pain should reduce, the BP should increase, the vomiting should subside. Then you need to gradually reduce the fluid from 3 to ml to stop the IV fluids or give them orally. So if you see this, the rate of IV fluid administration in the warning signs. So earlier the dengue was classified as 1 to 2. Nowadays this has been not used. So usually it goes from 1.5 to 3, 5. So 5 to 7, either you can come this way with a rising a dropping hematocrit, or you can go this way with again the rising hematocrit. If even after giving the 7 ml per kg per hour, if patient is not improving 7 to 10, then he is to be managed as dengue shock syndrome, which is a different management. So remember this, here they have managing the patient every 6 hourly. So it is better to manage for every 2 to 3 hourly. So the infusion rate changes every 2 to 3 hourly in dengue for every hematocrit value. This is a very, very important thing. How will you manage a dengue shock syndrome or severe dengue? So first you will give a crystalloids. Remember, you are already given 7 to 10 ml per kg per hour. The patient is not improved. Now what will you do is you give the fluid bolus. You will give 10 to 20 ml per kg per hour. Sorry, it is not per hour. 10 to 20 ml per kg for 15 minutes. For example, in the adults, it's 1200 for a 60 weight adult. So you give 1200 ml in 15 minutes, then give this same amount of fluid in the next half an hour to 1 hour. If this is improving, then you can reduce the patient to the patient's after giving the bolus. If the blood pressure has increased, if the patient's hematocrit is dropping, yes, the patient has improved. The patient's maintenance can be started with a 10 ml per kg per hour, again dropping to 7 and dropping to 5. If after giving this fluid bolus, for example, you have given this example 2100 ml stat for 15 minutes, then 2100 ml over for 1 hour. Even he has not improved, then you need to change the patient to the colloids. This is a very, very important thing. Don't keep on pushing the crystalloids even if there is no improvement, because this is going to cause a fluid overload, may add on to the patient's symptoms. So there are 3 types of colloids can be used, either 5% albumin or dextran 40 in normal saline or FFP. It is given at 10 ml per kg per hour over 1 hour. This is very, very important. So 10 ml per kg. So for a 60-year-old adult, it is 600 ml. So you can give this 600 ml over 1 hour, then you can assess this thing. Even after giving this colloid for 1 hour, if the patient has not improved, then he is labeled as persistent shock with adequate fluid therapy. Then you may consider the need for the vasopressor therapy, and there may be a need for blood products if there is evidence of concealed hemorrhage. So this is a very, very important thing. This is completely different from the septic shock syndrome. The septic shock, we usually give 30 ml per kg per hour fluid bolus. Then you maintain 15 to 20 ml per kg per hour. If it is not improving, then suddenly we'll go into the inotropic support. There is no role of colloids in the septic shock, but there is a role of colloids. That is only 3 colloids, either 5% albumin or FFP or dextran 40 in the dengue. So the rate of fluids in case of dengue is like this. You can go through this particular slide. So this is a very important thing. I've specifically made this table for you guys. So if the hematocrit is increasing and hemodynamic is worsening, then increase the IV fluids. If there is no response, then add colloids. This is the basic plan. If the hematocrit is decreasing, but if the patient is also worsening, then give blood. Maybe either a whole blood or a packed cell, a very, very important thing. Whereas if the patient's hematocrit is decreasing and the patient is improving, you can reduce the IV fluid. So this is one thing and very important thing, or the only thing which you should remember in case of dengue during the fluid management. Very, very important table. So when you pause or stop the resuscitation is when the patient's hematocrit is stable and there is no bleeding and there is cessation of plasma leakage, symptomatic benefit is improvement is there. SBP is more than 90, or if mean arterial pressure is more than 70, urinary output is maintaining and organ perfusion is impaired, CRP is consciousness is good, symptoms are not there, the capillary refill time is less than 2 seconds, extremities are warm, we can stop the IV fluids, allow them to orally. How to recognize the severe bleeding in dengue? I think this is taking a little bit more time, but this is a very important thing which I should consider here. How to recognize the severe bleeding here is, look, if there is overt bleeding, then it is not a difficult thing. But if very important thing here, as I told you, and stressing more and more here, is a decrease in the hematocrit with a fluid recitation, but with the hemodynamic instability, you need to suspect the bleeding. Or if there is a hypotensive shock, the low or normal hematocrit even before the fluid resuscitation. Like you have not started, the patient is suddenly presented with the shock, but his hematocrit is normal or low at the baseline, then he maybe have a bleeding. And if there is a refractory shock, has not responded to the crystalloids or colloids, or if there is a persistent or worsening metabolic acidosis in a patient who is well maintained with his blood pressure, but he is having a severe abdominal pain and tenderness. Sometimes you may not have any abdominal scans available. Sometimes you may not have any angiographies available in the emergency. But if there is a metabolic acidosis, which is very unexplained, with a normal blood pressure, with a severe abdominal pain and tenderness, this can be a feature of a concealed intra-abdominal bleeding. So it can demand patients for the blood transfusion. So this is very, very important. Some cases I have given here. You can go through this in the presentation which I will give you. One case of an expanded dengue syndrome I have included, which is presented with the HLH, and one severe dengue, how we managed, this has been also given. So the key factors in the success in the management is the education, give the community about the right approach and doctors about the right treatment, address the plasma leakage and shock syndrome urgently, and recognize the EDS. HLH needs to be managed with the steroids very early. So this HLH associated dengue infection has been increasing with the described in literature by the increasingly by the clinicians. So the proper use of the treatment guidelines by the trained personnel has significantly, this has been divided by the PAHO and the WHO. But again, I have told you, guidelines are not evidence-based here. The guidelines are purely expert-based. So always look for a liver of dysfunction, the myocarditis, the kidney failure, and encephalitis in the patient. And do not forget the metabolic acidosis, the electrolyte imbalance, glycemic alterations, the superinfections, and the HLH. So you are a physician, you need to look for these things in all the patients in the critical ward. So what are the current and novel approaches which are going on in the therapy? There are mainly three main therapeutic approaches. One is the natural plants and the marine organisms, some synthetic drugs, and some monoclonal antibodies in the era. So the flavonoids can be have an antiviral activity in the patient against the dengue. They act for the inhibitor against the DNA protease. So the flavonoids are promising. And also this terpene oils are under the research as a natural plant extracts to combat the dengue infection. And the synthetic drugs, although we don't have any drugs, but the targets has been addressing to target the virus directly, or just try to weaken the viral replication factors and also improving the body's immune response. So we have got in line the protease inhibitors like HIV and targeting the non-specific enzymes of the dengue. You can use the replication inhibitors, and the inhibitory effect of the corticosteroids on the cytokines have been investigated but not been proven yet. So that's why the no synthetic dengue drugs are currently available in the market. So now this mGon1 antibody, this is just in the trial for the West Nile virus, has also shown some effective against the dengue virus. Very, very important. So the one thing which as an Indians we should know that this is a Carica papaya leaf extract. That is CPLE, which is a promising target. So all the dengue patient nowadays, doctors putting this patient on Caripil. So many of the patients or students might ask, what is the actual role of Caripil? There are a lot of studies, especially in the part of Asia. Whenever you read a dengue, always try to read the articles from the Thailand or the Malaysia, and read the guidelines relating to Thailand and Malaysia, because these are the countries which have got a tremendous amount of dengue burden. So they have got a very good management guidelines for the dengue. So India also has got a good guidelines. So many of the Indian, Malaysian scientists have produced this significant amount of papers related to the CPLE. So I will be telling you the summary of this. The CPLE does have some protection against the dengue. So it increases the platelet production in the body by acting through the genetic mechanisms. And it is usually indicated when the platelets count is less than 50,000. So all the studies have tried this, and the patient counts has dropped 50,000, and they have shown the statistical significance to increase the. So what found me very interesting when I was going through the dengue, I think 1 year back, was the BMJ has actually given a guidelines regarding the use of the carica papaya leaf extract in dengue. So the BMJ is one of a very prestigious paper publishing site from the UK. So it has given the carica papaya leaf extract guidelines on how to prepare home-based preparation. Also, they have given a method, so you can go through this in the BMJ website. So to the summary, the tropical and subtropical regions are the major disease burden. There is globalization, which is increasing the spread of the disease. Many of the diseases are under the drugs are under the trial. Synthetic drugs are also being developed. The monoclonal antibodies may be a novel approach may see in the next 10 to 20 years. So the burden is very high. If not carefully managed, the dengue causes death. And the pandemic of the COVID has become a difficult challenge for the clinicians. And so it is very important to avoid the misdiagnosis of dengue as SARS-CoV infection, because the management is completely different. So the lesson learned from patient cases today are the challenges, the fatality rates, and the sharing experiences here. So the strategies to assess the dengue management are the dengue diagnostic tests. We should everybody know how to interpret the test, how to manage the fluids, what are the warning signs. Thank you very much.